Can we start ARNI in de novo hospitalized patient with HFrEF? Yes, of course, we can start ARNI in de novo hospitalized patient because the benefit which has been seen in patient with ADHF, we could easily get the idea that it improves the reduction in the rate of NT-proBNP as well as it reduces the CV mortality. So de novo heart failure, an escalating challenge. So global report heart failure registered in patient with hospitalized for heart failure, 43% the proportion of the patient had a de novo heart failure, and in prevent study that 66% were a newly diagnosed patient with HFrEF. So sacubitril valsartan, it keeps de novo HFrEF patients out of the hospital and helps them to live longer. And there is a significantly lower reduction, lower incidence of composite cardiovascular death or heart failure rehospitalization in de novo hospitalized HFrEF patients with sacubitril valsartan, and the difference started quite early, as early as 7 days, and the curve started to separate as early as 7 days, and by 14 to 21 days onward, you could see this huge difference that it helps in getting the patient out of hospital. So in transition study, this is a study where to assess the tolerability of the treatment as the proportion of patients who achieve the target dose of 200 mg BID of sacubitril valsartan at the end of 10 after randomization. This was the primary endpoint. So initiation of this therapy after hospitalization in a DHF patient with a newly diagnosed heart failure. So it could be seen that it improved the, it showed that there is an improvement in the outcome of such group of patients. Now, there is one interesting aspect with the sacubitril valsartan is the improved cardiac remodeling and pump function. We could see in our daily practice that those patients who are on ARNI, there is an improvement or trend in the improvement of ejection fraction, and the term improved ejection fraction with heart failure has been coined due to the effect of this drug in heart failure. So this changes in the echocardiographic parameters, that is in the reversal of remodeling. So there is a trend in the higher side. So those ejection fraction increasing beyond 50% or more than 10 millimeter reduction in LV and S diameter, significantly higher in those patients getting sacubitril valsartan. It also reduces high troponin T concentration in de novo hospitalized patients with HFrEF. There is a significant reduction, as you can see from the slides, in this sacubitril valsartan group. More de novo than prior HFrEF patients, they achieve the target dose of sacubitril valsartan 200 mg BID at week 10. So they are more likely to tolerate the drug, less chances of having hypotension or permanent treatment discontinuation. So transition study, it results showed that first-time initiation of sacubitril valsartan in de novo HFrEF patients, along with the initiation of other guideline-directed therapies, is feasible and is associated with better risk-benefit profile than in patients with prior HFrEF. Early intervention with sacubitril valsartan should be considered to delay the disease progression in patients with de novo HFrEF. 2021 update to the 2017 ACEI expert consensus decision pathway for optimization of heart failure treatment. It shows that it is one of the important pillars of therapy. So HFrEF patients stage C, ARNI should be the drug of choice, followed by ACE inhibitor ARB. Along with that, you add beta blockers and diuretic, and based on the associated data available, you can add MRAs and SGLT2 inhibitor. So clinicians should aim to achieve the optimal GDMT within 3 to 6 months of initial diagnosis of heart failure. So ESC 2021 guideline recommends ARNI may be considered as a first line of therapy instead of ACE inhibitor in HFrEF patients. In recently hospitalized stable patient with HFrEF, it is safe and may be considered as a first line of therapy. In HFrEF management 2021-2022 is ACEI guideline, as I already discussed, that patient with HFrEF and NOH class 2 to 3, the use of ARNI is recommended to reduce the morbidity and mortality, and it is chosen ahead of ACE inhibitor and ARB.